Today we are speaking about important subject, management of postmenopausal bleeding. What is the definition? Postmenopausal bleeding defined as any genital bleeding occur 1 year after menopause. What's the definition of menopause? It's a permanent cessation of menstruation for 1 year due to loss of ovarian function, and it is a retrospective diagnosis. What is the unscheduled bleeding in women taking hormonal replacement therapy? Defined as non-cyclic bleeding occur in this group of women. Cyclic bleeding is regarded normal, but if it develop non-cyclic, it is abnormal. Epidemiology, vaginal bleeding occur about in 9% of postmenopausal women. However, the incidence decreases with the age. Most of the cases occur during the first 5 years after menopause, and cases with endometrial cancer, over 90% of them present with postmenopausal bleeding. And also, the global incidence of endometrial carcinoma is increased due to increased risk of risk factor like obesity and late menopause. Etiology, the most important thing to exclude malignant etiology and then treat any cause. Our aim is to exclude malignancy by our workup. After that, we can treat any other etiology. We should put in mind what's mean negative test. Maybe test be negative for malignancy, but the clinician should be aware of possibility of false negative result. What is the differential diagnosis? The commonest atrophy, either vaginal and or endometrial, polyp, endocervical or endometrial, fibroid, and neoplasia. It's most dangerous and should be excluded, but it is not most common. Common is atrophy and followed by hormonal replacement therapy in Western country. But in our country, maybe atrophy is the most important, followed by polyp. Neoplasia we should be excluded either endometrial hyperplasia, carcinoma, or cervical carcinoma, or other genital malignancy like functioning ovarian tumor. The drug most common hormonal therapy, exogenous estrogen or tamoxifen, or phytoestrogen present in herbal or phytoestrogen. Non-gynecological condition should be put in mind, especially in very old age, and patient cannot know bleeding from urinary tract or rectal, and should be by detailed history or by inspection or examination. Other like foreign body should be in mind. Evaluation, detailed history, duration, frequency, length of the bleeding, quantity, relationship to coitus, maybe cervical, if it's relation to the coitus, past and family history. We should also ask for urinary and rectal symptoms. Clinical examination, general examination, looking for pallor, looking for is this maybe abdominal mass or not thyroid gland. Then speculum inspection first to see where source of the bleeding, is there is any ulcer or bleeding from urinary tract or in rectal area. Followed by speculum examination to look for lateral vagina and cervix, and by manual examination to detect any mass or lesion. And lastly, digital rectal examination to exclude any rectal lesion. Investigation most important after history and examination to do transvaginal ultrasonography and measure endometrial thickness. The cutoff level 4 millimeter for endometrial thickness, as we discussed later. Endometrial sampling, either outpatient bill biopsy or performed by blind DNC, dilatation and curettage, or most accurate hysteroscopy. Other investigation not needed in all cases like saline infusion sonography if we suspect polyp, or cervical cytology if we suspect cervical lesion, MRI and CT scan in some cases, with other cases of ovarian tumor or endometrial cancer. Endometrial cancer can reasonably be excluded by ultrasound if the endometrial thickness less than or equal to 4 millimeter and homogeneous endometrium. What is the indication of endometrial biopsy of the endometrial thickness more than 4 millimeter? If there is a repeated episode of bleeding after normal transvaginal ultrasonography or thin endometrium, or endometrial show diffuse or focal increase echogenicity, heterogeneity of the endometrium, or the endometrial not adequately visualized on sonography. Unscheduled bleeding when menopausal hormonal replacement therapy. The risk of pregnancy in this group is lower than that not taking replacement therapy. What's the upper limit to do biopsy? Yeah, about 8 millimeter of above more than 8 millimeter in first half cycle that indicate for endometrial sampling or biopsy. What is the treatment? Sure, treatment of the cause. Once we reach the cause or diagnosis, so treat it. If malignancy, refer to gynecological oncologist. In cases with endometrial hyperplasia without atipia, it's better to repeat endometrial biopsy every 3 to 6 months for 1 year. If reach normal endometrial, that's enough. If not reach, we need another treatment in form of hysterectomy. We can use either spontaneous follow-up or we can use Mirena or liver reducing IUD. We can achieve normal endometrium in about 90% of cases. Hysterectomy indicated if the normal endometrium is not achieved after 1 year, a typical endometrial hyperplasia, endometrial carcinoma develop or no improvement or persistent of bleeding. Sure, hyperplasia with atipia, which known as endometrial intraepithelial neoplasia, definite treatment is hysterectomy, no conservation in this case, or no Mirena for this group of cases. Atrophic vaginitis, local estrogen, endometrial polyp, sure excision at hysteroscopy and sampling of the rest of the endometrium for consent for hysteroscopy. What about guideline? We have two guidelines speaking about postmenopausal bleeding ACOG in 2018 and National Clinical Practice Guideline in 2022. Who assess most of the guideline that the assess should be by gynecologist and prompt assessment should be done. But in National Clinical Practice Guideline says that no need for gynecologist of the bleeding due to human replacement therapy. Not need for further investigation if except if repeated or like this. What's the cutoff level for sampling in ACOG if the endometrial thickness more than 4 millimeter in National Clinical Practice Guideline if more or equal? The difference here is in area of 4 millimeter. National Clinical Practice Guideline recommend to sample. What's about asymptomatic woman? Asymptomatic woman, we have sick endometrium. In ACOG, say no further investigation except in those with high risk factor for endometrial carcinoma. National Clinical Practice Guideline say it's better to or must to take endometrial sampling of endometrial thickness more than 11 millimeter. I'm thinking this opinion is more appropriate for treatment of the case of the endometrial thickness more than 11 millimeter need further investigation and sampling. What about if we cannot reach adequate thin visualize normal endometrium for these cases, or we cannot visualize endometrium in the transvaginal sonography? Most of the guideline recommend to be further investigation by sonography or office hysteroscopy or blind sampling. What about of blind sampling reveal negative result and there is persistent bleeding? Most of the guidelines recommend we do a hysteroscopy or repeat blind sampling. Recommendation and take-home message. Postmenopausal bleeding present diagnostic challenge due to its diverse etiology require comprehensive and collaborative approach by an interprofessional team. Should be what policy or guideline when to refer the case, what is the algorithm to manage these cases. Sure, for postmenopausal bleeding, malignant etiology should be excluded first. Endometrial biopsy is required of the endometrial thickness more than 4 millimeter. For those with on hormonal replacement therapy, if the more than 8 millimeter, indicate biopsy. For those asymptomatic with sick endometrium, if more than 11 millimeter, indicate biopsy. The introduction of outpatient endometrial sampling will reduce patient suffering by biopsy and decrease time taken to obtain histology instead of waiting for fitness or check for operation or scheduling for operation for the NC or hysteroscopy. Training for professional in hysteroscopy will improve patient care, sure, because hysteroscopy is more accurate than a blind biopsy. Thanks a lot for your